Thank you very much for inviting me today to come and talk to you. I have a presentation that I'll give, and then at the end, hopefully, if I haven't covered the questions, we can cover additional questions that have been sent in. Abby, if we could have the first slide, please. Can you all see that screen? So my talk today is really to try and give you some understanding of what radiation therapy is. And the reason for that is that radiation therapy, we know, is involved in the curative treatment of about 40% of all cancers, and also has a benefit for at least half of patients at some point during their cancer treatment. Next slide, Abby. One of our challenges, though, is that radiation treatment, unfortunately, has got a bit of an image problem. Obviously, when people think about radiation therapy, they often think about other forms of radiation or radioactivity, and that can be quite frightening. But in reality, radiation is something that we're exposed to almost daily. If you have a microwave, that's using radiation. When you go on a long-haul flight, you're exposed to radiation. And even obviously the sun is a form of radiation as well. So really, it's trying to make you aware of how radiation treatment can be used in a way that, if carefully administered, can be extremely beneficial and a very effective way of treating cancer. Abby, next slide, please. One of the other things to be aware of is that radiation treatment has been around for a very, very long time. William Röntgen was the discoverer of X-rays, and he did a lecture back in 1896 when he first talked about the benefits of X-rays. And just 3 years later, so just before the turn of the century, radiation therapy was used in the treatment of cancer. And if you look at the slide that's up at the moment, at the top far left, that's a picture of Gordon Isaacs. He was a 3-year-old boy who back in 1957 was treated on the first linear accelerator at Stanford University under the care of Dr. Henry Kaplan. He had a retinoblastoma, which is a form of tumour affecting the eye, and he'd already had his right eye removed at that time, but he had a small tumour in the left eye as well and was at risk of going blind. And he received radiation treatment over a course of 6 weeks, and that enabled the tumour to be effectively treated. He maintained his vision, and he went on to lead a normal life. However, radiation treatment delivery has certainly evolved over the last 100-odd years that we've been using it. And although initially we were using machines like the linear accelerator you can see in the picture that look quite old, and the radiation plans we were delivering were quite basic, we now have very high tech and very advanced technology giving treatment which is extremely localized and very carefully planned to deliver treatment that is very conformal just to where the tumor needs to be treated, and minimizing the dose to normal tissues. Next slide, please, Abby. So radiation therapy is essentially high energy X-rays, which are most commonly in the form of photon beams generated by most commonly a machine called a linear accelerator. And the aim of that treatment is to damage the DNA in the cancer cell. We know that cancer cells have a lot of faults in them, a lot of genetic mutations in them, and that means that when they're actually damaged, they don't always have the ability to repair that damage. And so radiation treatment is trying to ensure that we cause damage to the cancer cells, which is not possible to be repaired, versus treating normal cells, which, whilst they might experience some damage of their DNA, because they're normal healthy cells, they can repair and go back to normal functioning. Next slide, please, Abby. When we give radiation treatment, it's very important to be aware that we need to focus on planning it very carefully. So for those of you who are about to go through radiation treatment or have been through the radiation treatment process, you'll be aware that there's a number of steps in that process. First of all, of course, you meet with a radiation oncologist who will talk through with you why radiation is being offered in your circumstance and talk through with you what would be involved, how long the treatment would be, and what the potential side effects would be. The next step in that process is what we call a simulation process, where we're going to set patients up in a position that we will plan their radiation on, and also be a position that can be replicated and reliably put patients back into that position every day for the course of treatment, particularly as those treatments might go on for a number of weeks. In addition, the patients then during treatment will have assessments to make sure they're managing the treatment delivery okay and any side effects that they might experience. And then following treatment, we'll have a course of follow-up, which may be within the radiation oncology clinic or may be under another specialist. we have the next slide, please. So when we do radiation planning, and this is particularly for the most common form of radiation therapy, which is external beam radiation using linear accelerators, patients will initially go through a CT planning scan. And as we're doing that scan, we need to, as I say, make sure patients are in a position that's stable and that we can replicate. Now, it's actually very hard to just ask a patient to lie down on their back and stay still for the scan and to not move. And so we use a number of pieces of equipment to help patients maintain a treatment position. So if, for example, you're having treatment to the head and neck region, then you might have a special mask made, which is what's shown in the picture in the bottom right. That will enable patients to stay very still during that treatment course. Similarly, patients having, for example, breast cancer treatment will usually have their arms raised above their head and in a position that enables them to keep their arms still and stable for the whole course of treatment. But we also have to be mindful of what's going on, not just on the outside, but also on the inside of the body. And one of the things that can happen, particularly, for example, in prostate cancer treatments, is that the bladder and bowel can move every day, depending on how full or empty they are. And if someone has an intact prostate, so they haven't had their prostate removed, and the bladder moves or the bowel moves and is in a different position every day, that could also move the prostate. And so we want to try and minimize that movement. So again, we can ensure radiation is being delivered correctly. And so for that reason, we'll give specific instructions to patients regarding drinking fluid before a scan and how much fluid to drink, and similarly providing advice on how to manage their bowel function, and they might need to take some laxatives or have an enema to help with that as well. The other area where we have to be very mindful of treating is in the lung, and if Abby, if I could have the next slide up. What I'm showing you here is just two x-rays of a tumour. One is where the patient on the left has taken a breath in, and one on the right is where the patient is breathed out. And what you can see is there's a significant amount of movement of the tumour during just a normal breathing cycle. And so again, for that reason, when we're giving treatment for curative intent for lung cancer therapy, we have to be able to adapt for that movement. And so often what you'll find if you're going through a course of radiation treatment for lung cancer, you might have a number of scans done during your planning process, which is throughout the breathing cycle. And there may be various pieces of equipment that are used to try and minimize the amount of movement that you do have during that breathing cycle. So you may have a compression belt, or you may have equipment that may enable you to hold your breath. Similarly, when we treat breast cancer patients, we're mindful of trying to avoid the heart if they have a left-sided breast cancer. Again, we're often asking patients to do what we call a deep inspiration breath hold, where we're trying to expand the chest and to minimize that movement of the chest and therefore keep the heart away from the radiation. Keep the heart away from the radiation when we're giving the treatment. Abby, if we can have the next slide, please. So after we've done the CT planning, so if the patient has gone through the scanner and we have the images that we need, we then take those CT images and put them into a software planning system. And what this enables us to do is generate a radiation plan where we're covering the target of the radiation, which will be the tumour and any surrounding areas that could potentially be at risk of being affected by the tumour, but also wanting to identify those normal structures that we want to avoid, such as the kidneys, such as the heart, such as the spinal cord. And so our radiation planning is obviously focusing on targeting the tumour, but also trying to ensure that we minimise the exposure or keep the exposure of normal tissues to a level where we're not going to cause significant long-term changes. Abby, you can have the next slide, please. When you go through a course of radiation treatment, you'll hear quite a number of terms talked about, and one of those terms might be the dose of radiation that we use. The way that radiation is described is it's described in grey. And so, for example, a patient having prostate cancer treatment might have a dose of 60 grey in 20 treatments, but more commonly in radiation therapy, we talk about fractions. So 1 fraction is 1 radiation treatment. Most commonly, we'll treat patients on a daily basis, and usually that's a once-a-day treatment during the working week, so normally Monday to Friday. But sometimes we will treat patients twice a day, depending on the scenario. Sometimes might treat patients once a week or 2 or 3 times a week, depending, again, on what the intent of treatment is and the type of treatment that's being used. The standard radiation dose is 2 gray, but increasingly now we're using a type of fractionation called hypofractionation, which is a term, again, you might hear, Hypofractionation is where we give a bigger dose per day of radiation than 2 gray. So, for example, in prostate cancer, where we give 60 gray in 20 fractions, you would have a dose of 3 gray per fraction. So that is hypofractionation. The reason for doing that is that in a number of tumours, if you can give a bigger dose per treatment, that may be more effective in eradicating the tumour than a lower dose per treatment. It also has the benefit that it gives treatment in a shorter period of time. And so particularly for patients who are having to travel long distances for radiation or have to take time off work to have radiation, a shorter period of time is clearly beneficial compared to a longer period of time. But equally, we have to be mindful of the side effects that are caused. And so the prescription that you're given is the one that's going to be the most appropriate for your cancer, but also the most appropriate for side effect management as well. When we do give radiation treatment, it's almost predominantly done as an outpatient treatment. Sometimes we do deliver radiation as an inpatient. That more commonly is when patients may have significant pain issues or potentially are having issues with mobility. That means coming for treatment daily would be difficult. But most patients are having treatment as an outpatient. When you have treatment delivered, the appointment time is commonly around 15 minutes or so. The actual time of treatment delivery, where the radiation beam is on, is a lot shorter, but a lot of the time that we spend during the treatment appointment is actually getting the patient into the room, onto the radiation couch, in the position they need to be with the various pieces of immobilization equipment. And then, as we'll see on the next slide, also doing imaging to confirm that the patient is in the position that we want them to be. So what's really important with our treatment delivery is that the treatment is going to the right place. And with our modern technology now, most if not all linear accelerators have the ability to do what we call cone beam CT imaging. And that's where the machine, the linear accelerator machine, can actually do a mini CT scan of the area that we're treating and develop an image that then can be superimposed on the radiation plan to ensure that the patient is set up in the correct position and that the radiation treatment, when delivered, will go to where it's supposed to go. If things aren't quite matching up, then the radiation therapists who are on the machine can adjust the couch and adjust position so it does match. So that's happening every day to make sure that the treatment is being delivered to the right site. When the treatment is being delivered, patients are in a room on their own. So the treatment room is what we call a bunker. So radiation obviously is something we want to keep contained. We don't want it just going anywhere. So when you're actually having the treatment, you're in the room on your own. But there are microphones, there are cameras in the room. So at all times, the treatment team can see you. And if at any point during treatment delivery there is a problem that you feel uncomfortable or you have concerns about anything, you can call out, put your hand up. The team will switch the machine off and come into you immediately. So whilst you're physically on your own, someone is always able to see and hear what's going on. When the treatment is being delivered, you won't actually see the x-rays because x-rays are invisible. You'll just see and hear the machine moving around you, but nothing will physically come into contact with you apart from an immobilization device that you're already in, such as a mask. So the machine itself doesn't touch you. Once the treatment has finished, then that means the radiation beam is gone. So the machine switches off. And then just like a CT scan, there's no radiation anymore. So you're not radioactive, you're not a risk to anyone. You can be going out of the room and being around young children, babies, pregnant women, other people without any concern. It's like a scan in that respect. The next slide, please. Now, the side effects of radiation are dependent on the part of the body that we're treating. Radiation is a very localized treatment, so the x-rays are going to a particular part of the body. And so the side effects you'll experience will depend on the part of the body that's being treated. If you're having a head and neck cancer treatment, for example, then you'll get side effects in the head and neck region. So that might be that you get soreness of the mouth or the throat. You might start getting a skin reaction on your neck and around your chin. If you're a man, you'll lose your beard or your moustache. Patients might be aware of alteration in their taste. They might start to develop a dry mouth. And so those side effects are very specific to the part of the body that's being treated. Similarly, if you're having radiation to your prostate, then you might start experiencing inflammation and irritation of the bladder and the bowel. And so that can mean that you're wanting to go to pass urine more often, or if you do need to go, you need to go more quickly, you can't hold on. Similarly, with the bowel, you may feel you're needing to go more frequently. And so those side effects will continue during the course of radiation. What we call early side effects will continue during the course of radiation and go on for a number of weeks. And that can vary, but often can be around 6 to 8 weeks in duration. The other early side effect that virtually all patients with having radiation treatment experience is fatigue. And that fatigue is a general feeling of tiredness that can vary. Some patients find that they just don't do as much in the day as they might expect, or may just feel they have to have an earlier night. Other patients do struggle a lot more and physically find they have to rest, even if they don't sleep, but have to have a rest every day. That's not to say if you feel that way that there's a problem or there's something wrong with you. It's just everyone reacts to radiation differently. And similarly with the early side effects of radiotherapy, some people's skin reactions, for example, can be a lot more intense than others. And that just again seems to reflect the individual radiosensitivity that people have. There are side effects, though, that can develop long-term after radiation treatment. And again, these are dependent on the site of the body that we're treating, but these side effects may not become apparent for several months or even sometimes several years after radiation therapy. So, for example, patients having breast cancer treatment where the breast is treated, the tissues of the breast do become firmer over time. And so that can lead in some women over time to some reduction in size of the breast. The chest wall muscles that are in the radiation field directly beneath the breast tissue also become tighter and firmer over time, and so they can cause some discomfort when moving, or people can be aware that when they're moving their arm around, it just feels firmer or tighter. Similarly, patients who have head and neck radiotherapy might have some permanent alteration in their salivary gland function, so may continue to have some dryness of the mouth. That can have an impact on dental health, and so it is important that prior to radiation starting, people are having a dental assessment to ensure any teeth that are at risk of needing future dental work are removed to minimize the risk that there will be problems in the long term. So there are a lot of side effects that are very dependent on the side of the body that's being treated, and your radiation oncologist will talk through with you in more depth what they are and what the risks of those could be of you developing them, whether they're common, moderately common, or rare. And that obviously has to be balanced against the risk of the cancer coming back or the risk of you not having an effective treatment with the radiation at the time it's being delivered. Next slide, please. There's also a form of radiation therapy that you might have heard of, which is called stereotactic radiation therapy. So that is a form of external beam radiation treatment that I've already talked about. The difference is that this is giving extremely precise radiation beams, so very small areas of the body being treated with very high doses per treatment, so that typically these radiation courses are only up to about 5 treatments in total. So we can then give a much bigger dose per treatment and therefore, again, have quite a high chance of eradicating the tumour. But it's really important because of the high doses that are being delivered. It's very precisely planned because there is a risk if you don't treat the correct site and are treating a normal tissue, you could cause significant damage. And therefore, you have to carefully select patients who are suitable depending on the location of their tumour, but also dependent on their ability to maintain the very strict requirements for immobilization that are needed to keep patients still so that they're not moving around during treatment and risking the beam going to the wrong place. Next slide, please. There's also another form of radiation therapy which you may be aware of, and this is called brachytherapy. So brachytherapy is where we're using a radioactive source, and that's a source that has radiation that travels only a very short distance. So we can give a very high localized dose, but only over a very short distance, potentially just a few millimeters. Because of that, we need to place the radioactive source into the body. And so it's usually used for very localized small tumors that are in very accessible parts of the body. So for example, on the slide that you're currently looking at, this is prostate cancer brachytherapy with seeds, radioactive seeds that are placed into the prostate gland and therefore give a very localized dose to the prostate. The advantage of brachytherapy is that it is a very precise administration of radiation treatment. The radiation is only going where you place the seed or where you place the implant. and the radiation is only traveling a short distance, so the risk of causing side effects to surrounding normal tissues is much less. But the challenge of this type of radiation is, again, it has to be very careful patient selection. So this isn't suitable for all patients, and it's only suitable for those patients where your tumor that you're treating is very localized and only requires treatment to that area, as opposed to treating more extensive lymph nodes or in a part of the body where it's very difficult to actually get radioactive seeds or implants into. Sometimes it can be used in conjunction with external beam radiotherapy. And again, it may be used as a booster dose. So you give standard external beam radiation therapy initially, and then you might put what we call high dose rate implant brachytherapy into the tumor at the end of the treatment for maybe 2 or 3 fractions to give a higher booster dose at the end to, again, try and give a more high total dose without damaging normal tissues. Next slide, please, Abby. This is just an example of how it's administered. So you often will have this is a high dose rate brachytherapy. So as opposed to the seeds that you saw in the slide prior, in high dose rate brachytherapy, we have a radioactive safe, which is what you're seeing in the middle. And then the number of cords or applicator lines come out, and the applicators are actually placed in the body. So on the left-hand side, you're seeing a cervical cancer treatment where there's radioactive applicators have been put inside the cervix and into the uterus, and the radioactive source travels into those applicators, stays there for a fixed amount of time, which is usually a number of minutes, and then is removed. And as you can see on the far right of the slide, that the brachytherapy plans are very similar to external beam plans, and that you need to work out it precisely where the radiation dose is being delivered to ensure that you're minimizing the radiation dose to normal structures. So this plan is for a prostate, and is trying to ensure we minimize the dose to both the rectum and to urethra, which travels straight through the prostate gland. Next slide, please. So radiation is actually used in pretty much all cancers. Most cancers would benefit from radiotherapy either as a definitive treatment, as a pre or post-operative treatment, or fortunately, if we're not in the curative situation, in a situation where palliation is needed, particularly where we're looking at controlling pain or controlling bleeding, or where there's pressures on nerves. There's also a role of radiation treatment in the management of benign disease, and it can sometimes help in early stage Dupuytren's disease. It can be used in thyroid eye disease, and also is used in certain joint conditions as well. So there are a significant number of applications for radiation treatment. Next slide, please. One of the questions that was asked is, if you've had radiation therapy, can we treat with radiation again? And there are 2 situations to be aware of when we think about this. One is where you've had radiation to one part of your body, and then radiation might be needed to another part of the body. And certainly there's a definite capacity to retreat with radiation if it's a different site. Most of our restrictions on retreatment are to do with the normal tissues that surround the tumor or close to the tumor that's being treated. So in some scenarios, you may be limited in how many times you can treat an initial area that's been treated once. So for example, if a tumor is very close to the spinal cord, it may be very difficult to give a second treatment to that area because of the risk of giving too much radiation dose to the spinal cord and the damage that may cause. But if, for example, a patient had radiation to their prostate, but then unfortunately developed in the future a tumor deposit in the bone, in the higher up in the spine, then being a completely different site, that's very amenable to retreatment. Again, if you are in a situation where you've had radiation previously and more radiation is being considered, the radiation oncologist will take into account the treatment you've already received, the time since that treatment, and then work out if more treatment is possible, if it's in the same place, or if in a different place, it almost certainly would be possible to offer further radiation in the future. Next slide, please. One of the other challenges, though, to be aware of with radiation is that currently in New Zealand, radiation is delivered in 6 public centres throughout the country. So I'm based in Palmerston North. There's also radiation centres public centres in Auckland, Waikato, Wellington, Christchurch and Dunedin. And in Tauranga, the private centre there, KKC, also delivers public treatment to the Bay of Plenty residents. And as you can see from this slide, the location of the public centres means that some patients have to travel a significant distance to get to have treatment. that obviously has implications for people who have families, have work commitments, have potentially stock commitments if they're farmers, and how they manage that. But even patients who live locally, just the coming every day for treatment can be challenging, again, just for family and work commitments. We are fortunate that we have a lot of support from the Cancer Society, who help us with volunteer driver and shuttle services. And they also support accommodation that provides for patients who are travelling at a distance to the treatment centre, so that during the time they are requiring treatment, they can have accommodation. So, for example, in Palmerston North, we're very lucky to have Osnam House, which provides accommodation for people living a distance from the treatment centre. But there's also a wish to see, if possible, if we can deliver more treatment closer to home. And at the moment, at our service, we're looking to develop an outreach satellite site at Taranaki Base Hospital, which hopefully will open next year and will certainly make it a lot easier for our Taranaki patients to receive radiation, where many patients will no longer need to travel. There's also been considered in Hawke's Bay, and the Auckland Centre are looking at opening in Whangarei. So we're trying where possible to make it more accessible, but it is still going to remain an ongoing challenge just because of the need for often giving several treatments over a number of weeks for patients to have the time to attend. And we do acknowledge that can be very difficult. Next slide. So I hope I've provided some insight into what's involved with radiation treatment, and certainly not all radiation treatment is the same. And I'm aware that people's experiences are very different, and sometimes previous experience can influence your decision making. But I would counsel you that if radiation is being considered for you, do meet with a radiation oncologist and talk through what would be involved, as certainly people's experiences isn't the same. And whilst you may feel fearful of what's involved because of other people's experience, what may be being offered for you could be quite different. So do take the time to consider all options that are being offered to you. So that was the end of the presentation I was going to give. I am aware that there are some further questions, and one question that came through was in relation to the timing of radiation therapy for breast cancer patients who've gone through neoadjuvant chemotherapy, and what the thinking about radiation is in that scenario if patients had a complete pathological response. So the situation that's being described is in breast cancer now, increasingly in a particular type of breast cancer patient, chemotherapy may be given up front, and then a patient goes through surgery. And if at the time of surgery, when they're looking under the microscope at the tissue that's been removed, if they can't identify any cancer cells in that tissue, that would be called a complete pathological response. And so the question is whether or not radiation should then be offered to the breast after this treatment response. The answer is we're still not yet certain of the best way forward. There has been a few meta-analyses recently, so that's where they do an overview of a lot of trials that have been done. And it's still not definitive what the best way forward is. There is still an indication that there is improved local control if you give radiation therapy to the breast after a complete pathological response following surgery. And so there is still not clarity, even in patients who appear to have no nodes involved. As I say, the tissue looks clear. There's no clarity to say definitively you can avoid radiation treatment. It might be the radiation treatment would not be to the whole area that was initially involved with cancer, so it wouldn't necessarily involve covering the lymph nodes, but the breast would certainly be probably advised to be treated. But it's still an evolving area. There's a lot of trials still being done in this space, and so there isn't definitive guidance, and often it will come down to a discussion again with your oncologist as to what they think might be the best for you, and also considering the side effects that would be involved based on whether particularly this was a left or right-sided breast cancer. I don't know if that answered all the question that you were hoping to get information on, or if there's something else you wanted me to go through for that.
Right, I've unmuted myself now. Thank you, Claire. That you will move into question time now, but just at the end of your presentation, you were talking about people going through all of the choices. And sometimes in those outer regions, you might be assigned to a specialist who's obviously not an oncologist, but might be a urologist or something else, or a surgeon. And so how would someone get to contact all of the different specialists to help make those decisions? So I'm not sure that everyone easily gets that on tap, so to speak, to make that decision. An example I would give is that if you've got a surgeon locally, that probably, you probably tend to go surgery rather than radiation, but that isn't always the case.
So what should be happening is when patients have a cancer diagnosed, whoever has diagnosed the cancer, whether that be a surgeon, for example, in a lot of bowel and prostate and other types of cancers, or a lung cancer where it might be a respiratory physician, they should be bringing that person's case to what we call a multidisciplinary meeting. So that's a meeting which is usually tumor specific. So it might be GI cancers or gastrointestinal cancers, breast cancers, lung cancers. That in that meeting, there are not just the specialist physicians or surgeons, but also radiation oncologists like myself, medical oncologists, radiologists, pathologists, specialist nurses, various allied health professionals are also present. And so at those meetings, the person's cancer is discussed, the stage of their cancer is discussed, and then the options for treatment that would likely give the best outcome are also discussed. And in sometimes there are equivalent options. So it could be surgery versus radiation therapy. For example, in prostate cancer, you might say they both have equivalent outcomes, but the patient should still be given the opportunity to discuss those options with the relevant specialist. So what the basis of the MDM is to ensure that those discussions are taking place and a recommendation is made. And the surgeon, if it is recommended the patient have an opinion with a radiation oncologist, should action that referral. And whilst I do acknowledge that some of our rural and more provincial areas do struggle with access to clinics, a lot of the centres do visiting clinics, or there is the opportunity to do telehealth clinics. So there are ways that people can access a specialist advice if required.
That sounds really encouraging to think that it's discussed at a good cross section or a good level of detail. There's a question just up on the Q&A chat, which people can post. So there was one here, I'm not quite sure, Sunita, it's with regard to so it can't access lymph node. I'm not quite sure what that's meaning. You may understand, Claire, I guess.
Radiation therapy can essentially get to any part of the body. It's X-rays which are very penetrating. And so the radiation can get to lymph nodes. It can certainly get to quite deep structures, such as in the pancreas region as well, can get to spinal cord. If you have a spinal cord tumor, can treat the brain. So radiation can actually get pretty much to any part of the body. The challenge of radiotherapy is ensuring that you're delivering it in a way that is safe based on the dose that you're wanting to administer to be effective versus the normal tissues that are surrounding the tumor that could be impacted. So there can be restrictions to how much dose you can give because of the normal tissues in that region. So it might mean the radiation has to be given as a combination where you have surgery and radiotherapy, where surgery might be given pre or post-operatively, or you might give radiation with chemotherapy or other treatment that makes the radiation dose more effective than compared to radiation on its own. But yes, radiation can definitely get into lymph nodes if needed.
Did anyone want any further clarification on that specific point? If you want to, just hold the spacebar down and feel free to ask. No? Okay, there's another one there that asks, how is success of treatment actually measured?
So traditionally, when we look at success of cancer treatment, obviously one of the ways that you would measure that success is with survival. So when we look at clinical trials that have looked at cancer treatments, usually one of the outcomes we look at is patients who haven't had the cancer treatment under investigation versus the treatment that is under investigation, and compare their overall survival, and have the patients who've had treatment achieved a better survival than those who didn't have the treatment. Sometimes we don't look at survival. Sometimes we look instead at what we call disease-free survival. So that's where the cancer is not active or impacting on a patient, but then becomes active at a time in the future. So you've got a disease-free period. And again, is the cancer treatment increasing that disease-free period? And then because radiation is a local treatment, then another area you can look at is local control. So does it reduce the risk of the cancer coming back in the particular area that we're treating? It may not have an impact on the cancer elsewhere, but it may have an impact on the local control of the cancer in the area that you treated. One of the problems we can face with radiotherapy, though, is that because radiation isn't physically removing something, you can't tell that you've got it all out, or you've eradicated everything. So you are often reliant on serial imaging, for example, to check that, say, for example, in a lung cancer, that the tumor that was there is either shrinking down over time or becomes a sort of a permanent scar that's no longer growing. In prostate cancer, we will monitor PSA, which is a blood test, and that will tell us that the PSA is going down after radiation, indicating the cancer has responded. And if it remains low, or in patients who've had a prostatectomy where they shouldn't produce PSA at all, they have no PSA, then again, that's telling you that hopefully the treatment has been effective. In breast cancer cases, where we're often giving radiotherapy after surgery, one of the problems is that we're treating there to reduce the risk of relapse in the future. So if there were microscopic cells there, the radiation is aiming to prevent them growing back and causing the cancer to recur. And of course, because we can't be sure if there are microscopic cells there, and therefore we're treating to reduce risk of relapse, you may never know if the radiation has done what you wanted it to do, because you never get a recurrence and you don't know if that was due to the radiation or not. So that gets harder to measure. But the reason we know that radiation, in particular in breast cancer situation, is effective is because of the clinical trials that have been done over many years in large case series across the world, where they've looked at different outcomes for patients who've had radiation and those who haven't, and seen that in patients who didn't have radiotherapy, their local regional control, and in cases as well, their survival was worse. And so we know it does have an impact, but on an individual basis, it can be difficult to say that radiation has been effective in their particular situation.
Right. There's a few more coming in, Claire. Are you able to read those as well down the side?
So does high dose vitamin D taken prior to radiation help mitigate side effects that may accompany breast radiation? Are there any dangers of radiation of taking supplements such as vitamin D, magnesium, and zinc? So certainly during treatment, we want people to maintain a healthy diet. And what we are mindful of is, and if I'm not going to go back to the presentation, but one of the things that we're wanting to do in radiotherapy is cause damage to the DNA. So we're causing DNA breaks. And one of the ways that the radiation works is that as the radiation is delivered, it creates what we call free radicals in the cell. And those free radicals fix the DNA damage in the cancer cell. So ensure that the DNA remains damaged and therefore leads to the death of the cancer cell. There is a theoretical concern that if you give treatments that are going to mop up those, if you take supplements or take treatments that mop up those free radicals or reduce free radical production, that might counteract the effect of the radiation. And so you may find that when you're going through treatment, you may be advised to not take supplements that are like high levels of antioxidant therapy that potentially will mop up free radicals. It's a theoretical basis to that in relation to the free radicals that we need to make the DNA damage work. I would say your normal vitamin supplements that you get off the shelf in a pharmacy or a supermarket are unlikely to have any impact. And if they make you feel better and help you cope better with how you're feeling and therefore dealing with the radiation you're going through, I don't think that's an issue. If you're taking very high levels of antioxidants and having intravenous treatments, there is a potential risk there's an interaction. Therefore, we'd be reluctant for you to take those supplements if that was the case, or at least have a discussion with your radiation team around what you're wanting to take and confirm with them if they're comfortable with you taking that or not.
Right. So Julie was asking, if you've had a mastectomy with immediate implant reconstruction, does that change whether or how you'd get radiation to the breast?
So it doesn't mean you can't have radiotherapy, but what we know with radiation to patients who've had an implant put in is that there is a risk that the radiation can cause fibrosis or scar tissue to form around the implant, something we call a capsule, and that can make the breast area very firm and has the potential to change the cosmetic appearance of the breast. So in patients who are having implant reconstructions who then need to have radiotherapy, I certainly counsel them on the risk that you could have that capsule formation develop that could impact on the cosmetic appearance of the implant. Plastic surgeons, though, have the potential to go back at a later date and correct that if that happens. And we are mindful when we're doing our radiation planning of trying to avoid exposing too much of the implant or the tissue surrounding the implant to the effective radiation. But obviously at our forefront is we want to make sure we effectively treat where the cancer could be. So the radiation plan will be created based on how best to cover the area that's at risk of cancer, but it could be that a side effect is that it does affect the implant appearance in the longer term because of capsule formation.
Another question here I have that came through. Does radiation continue to be active in the body after radiation treatment is finished? And if yes, for how long?
So as I talked to you about during my presentation, radiation has early and late side effects. And the reason for that is when radiation is delivered, the radiation is just there for the time that the beam is on. So it's there instantaneously, effectively. But what persists in the body afterwards is the changes in the DNA of the cells that are affected by the radiation. And the effects of those DNA changes may only be evident many months or years afterwards as the tissues are repairing and recovering. So whilst the radiation itself is only there for the time that you're in the machine and the time that the beam is on, the effect of the radiation, the early effects where you've got more of the fatigue, maybe the skin reaction, potentially the bowel and bladder changes, and that are much more noticeable, they may only be there for a number of weeks, and the severity may vary depending on an individual. And as I say, some people seem to struggle more than others. But on average, those early side effects are there for several weeks, and we usually qualify them as up to 3 months. But then some tissues can develop permanent changes or certainly be different in their structure, so tissues can get firmer for many months and sometimes years afterwards. And so some side effects may not even be evident until several years afterwards. And that's because of the changes in the DNA that occurred in the normal cell at the time the radiation was delivered. So the radiation doesn't stay in the body as such, but the effects of radiation can be evident for quite a long time afterwards.
Thank you. There's another one that we got through, and you covered this a little bit with regard to the measurements of the radiation doses. So the question is a 40 GY and 15 fractions considered to be a hefty radiation dose? And in what circumstances would you consider reducing such a dose? And they qualify this by saying this is for post-NAC PCR for HER2 plus breast cancer.
Yeah. So, and I can also see there's another question about strata XRT. So I might talk about that first, and then I'll talk about the different breast radiation. So, strata XRT is a cream or a gel that is applied to the skin in an area of radiotherapy of the radiation field. So it's a daily application. It can be used in breast cancer patients. It can be used in head and neck cancer patients. It can effectively be used in any part of the body where you're going to get quite a significant skin reaction. I would be applying it to basically the site of where radiation is being delivered to. So if it was a breast, I'd be delivering it across the whole of the breast region. The radiation beams, when you're having breast treatment, sort of come across the chest, that what we call tangential predominantly. And so the whole breast or the whole chest wall in that area, and potentially in the lymph node area and the armpit, if that's also being covered, is at risk of having a skin reaction. So I would be advising you to put it on the whole breast region. Again, your radiation therapists can again guide you as to where you should be applying it to minimize the reaction. The second question is around the 40 gray and 15 fractions. So as I said before, gray is just the way that we describe the dose of radiation that's being delivered. Many years ago, when I first started training, the standard dose of radiation to give a breast cancer was 50 gray and 25 fractions. So that's 5 weeks of radiation treatment. Over the years, there's been a number of studies done that have looked at what we call hypofractionation. So that's where you give a bigger dose per day to give a treatment in a shorter period of time. But because you'll be giving a bigger dose per day, you then don't need to give as high a total dose as you would have done if they were having it in 2 gray per fraction, because the bigger dose per day is having a bigger effect than a lower dose per day. So 50 gray in 25 fractions is effectively equivalent to 40 gray in 15 fractions, and is effectively equivalent to 26 gray in 5 fractions. So in the last few years, the Fast Forward trial that was done in the UK showed that in breast cancer patients, you could give a bigger dose again and give treatment in 5 days, which gave equivalent cancer outcomes to 40 gray and 15. So we can look at changing the dose, but you do have to be mindful of the structures that you're treating. So certainly predominantly in my practice and most practices in New Zealand, we tend to use 26 gray and 5 fractions to the breast when we're only treating the breast and not treating the lymph nodes, because there is a concern that 26 gray and 5 fractions may just be a little bit too big a dose for lymph node treatment as well. And we're waiting for longer term data for that. In relation to the question about whether you can reduce the dose, that hasn't yet been studied. So at the moment, the question is whether or not you would give treatment at all and whether it's needed, as opposed to reducing a dose. So at the moment, there isn't an indication that you would give maybe 30 gray and 15 fractions rather than 40 gray and 15 fractions. The question would be whether you give 40 gray and 15 or 26 in 5 based on the radiation field that's being delivered. It's very uncommon now to get 50 gray and 25 fractions.
So there's another one there just asking a little bit more about the cream. Haven't heard of the cream. Can I apply it as well and buy over the counter?
So I'm not surprised people haven't heard of the cream. The reason is that it's not publicly funded. It is quite expensive. My understanding is it's about $200 or $300, and you buy it online, is my understanding. You'll probably again have in your own radiation departments, they have other creams that they will provide you. So in our own department, we have a number of creams we provide patients. There is also another product called Mepitel film, which is a film dressing that people can buy and put on the skin at the time of starting radiation treatment. So Strata XRT is just one product. There are other products out there, and your radiation treatment service will also almost invariably have creams they will give you as well that you don't have to pay for.
Just talk a little bit more about the radiation fatigue. It seems that there's been more and more discussion about cancer fatigue or radiation fatigue, and just fatigue in general. What experience do you have with people over a longer term? I guess going through treatment you probably feel tired, but even in recovery or time after that.
Yeah, and the tiredness can go on for a number of weeks afterwards. And as I said before, the degree it affects people is very variable. I think it's really important, if you can, to keep active. And doesn't mean you have to be doing really high intense exercise, but just getting out every day and going for a walk. We know that physical exercise can be helpful. And also because some of the side effects of the treatment we're giving does mean that you may find your muscle strength or stamina is not as good as it would be. For example, prostate cancer patients on hormone therapy, that particularly can affect you, and often hormones are given with radiation for prostate cancer. Maintaining your activity and exercise can be very helpful. It's also a good way to sort of psychologically be doing something for yourself, because a lot of what's being done to you during a cancer course of treatment is being done to you. You have very, very little say in what's happening to you. Whereas doing things like your exercise, making sure you're eating a healthy, well-balanced diet, these are all things that you can take control of and do for yourselves. But fatigue definitely can have a significant impact on people. And my advice is to just gradually build up your level of exercise, but be kind to yourself. It is going to take some time, and don't expect to be able to go back to immediately what you were doing just before treatment. It can take several weeks, and in some cases even a few months, to really start feeling as though you're properly back to the activities that you were doing before, particularly if you're also having chemo or surgery as part of your treatment.
Right. I'm just going to open it up to voice questions. Is there anyone that would like to I know we have another one on the chat line, but is there anyone that would like to ask a question by voice? Simply hold your space bar down and ask. We've got about 10 minutes to go, so let's make the most of the opportunity. Come on, there must be somebody. I'm sure you're sitting on the edge of your seat there. I'm going to ask one then. On some of the slides there, one of the slides you had, particularly all of the different kind of colours when you're looking at the body. Are they do they tell you where tumours are in harder parts of the body or softer parts? What good value is that for you?
So what you might have seen was some of the radiation plans where they had all the different colours. And really the colours are sort
Yes.
of telling us where the most intense dose is. So really the high doses. So that's often usually the red areas. And then a bit like it is a gradient, a dose gradient, a bit like you might see a gradient on a map with the contours of a hill or something. You see the gradient fall off. As you go away from that area, then the dose reduces. And so then you find the colours go down into the greens and the blues and the very low dose areas, which are not being exposed to significant amounts of radiation. So it's really just a visual representation of where the high dose is going to, and then the lower dose areas are the much cooler colours. So
Right.
it's just a helpful way to understand where the dose is going.
So when you're actually on the machine, and I know it kind of rotates around you, are there some parts of the body that you would treat from different angles? Is it, or is that how it works as it rotates around?
Yes. Yes, so the machine itself, the head of the machine, within the head of the machine, there are lots of little lead leaves that come in and create a very conformal shape. So it's not just a square, it could be all sorts of shapes that are created to really make that treatment beam as tight and as conformal to the tumor as possible. The the machine itself obviously can rotate around you. The head of the machine can also change its position, so that can also rotate, and the couch you're on can also rotate. And what that then means is not only can you have the beams going in one plane, you can actually have the beams going in planes in different directions as well. And that's particularly what we might use in someone who's having, for example, a tumor in the brain treated. So the machine is actually quite adaptable to enable us to move people around. One of the main things we do require, though, is usually patients have to be able to lie flat. And I know that can be a challenge in some circumstances, but we do need people to be able to lie flat. Isn't always on your back. So I've obviously shown you pictures of patients having treatment on their back. We occasionally treat patients on their front, depending on the type of cancer they're having treated. But being stable and able to replicate that is the most important thing that we do.
Right. Hence the tattoos and then the realigning each time and things like that.
Yeah,
Yeah.
yeah.
At a
Sorry.
recent meeting, I remember some of the guys saying that one of the things you don't want to do is lose a lot of weight during, a 6 or 7 week session because your tattoo locations should change. You should try and stay as stable a body shape as possible. Is that had been a problem for big
So
weight loss and that sort of thing?
So weight loss can be an issue, particularly again in cancers where we're treating areas of the body that require to eat with. So head and neck cancers, esophageal cancers, even some lung cancers, because you may be inflaming the mouth, throat, or esophagus, it can be very painful to eat and drink because of the reactions that you're developing inside the mouth and the throat. And so people can lose weight unintentionally because they're not wanting to lose weight, but just because of how the radiation is affecting them, they end up losing weight. Often these patients are being supported by a dietitian. They might have supplemental feeding, which might require even a peg tube, a tube that's placed into the stomach to aid with feeding, or down the nose to aid with feeding. But what we sometimes will do is, if when we're treating patients and we can see there is weight loss developing, what we'll do is do a replan and a rescan and a replan. So we might ask a patient to, during their treatment, have another CT planning scan and create a new plan to ensure
Right.
that we're accounting for that weight loss, so that we can continue treatment and continue to deliver treatment safely. Because the problem with the weight
Right.
loss is, obviously one thing could be you're not actually getting the beams to the right place, but more of a risk can be that you're getting the beams to the right place, but the other organs around the tumor that you're trying to avoid may be closer and could inadvertently get more dose than you want them to, which you want to avoid. So that's why we end up doing rescanning and replanning in those situations.
Okay. Coming back to the questions on the Q&A on the side there, there's another one that talks about the my 26
Yep.
GY and
Yep.
fractions was being delivered over 7 days.
Yep.
Yep.
So
And then
that's
just talk
quite
about
normal.
the day.
So radiation treatment is delivered during the working week, but that doesn't mean you'll start on a Monday. So some patients may start halfway through the week and then have a gap over the weekend and then complete treatment the following week. That's perfectly acceptable. When radiation doses and treatment courses are developed, they acknowledge the fact there will be breaks for weekends. So that's not an issue, that there's a 2-day period where you're not having treatment over the time that you're having a course of 5 treatments. That's fine.
Oh, so a pat on the back for you here. You're doing a great job. What future advancements in radiation treatment do you see?
I think there's going to be increasing technological developments around our accuracy of delivering treatment. So our machines, I think, are going to get more and more precise as time goes on. I think we're also going to probably be better at adapting our radiation plans more quickly, accounting for patient movement better. There is some research going into giving even higher doses of radiation, so you may even only need treatment in a single dose rather than over multiple courses. So there is a lot of research around how we can develop treatment. I think one of the big areas, though, that is going to potentially come a lot more common in the next decade or so is our understanding of the genetics of cancer. So those cancers that are more likely to recur locally as opposed to recur at a distance, and therefore where radiation may be beneficial or even could be avoided depending on the genomic profile of the tumor. So I think understanding a lot more how the cancer is going to behave based on its genetics will help guide us to either give more radiation treatment or as has already been alluded to, de-escalate or even not give radiation treatment. I think that's something we're definitely going to see as time goes on.
The next question is, are there any imaging methods that perhaps may not be publicly funded that could identify the presence of microscopic cancer activity?
So at the moment, most imaging techniques require there to be a volume of cancer visible up to about 1 or 2 millimeters, which is not microscopic disease. So even PET scans, which a lot are now publicly funded. So PET scan is a CT scan compared with a radioisotope that's injected into the body that then can specifically target where cancers are and light up on the scan, showing you where the cancer is. Even with PET scans, you need a certain volume of disease to be present, so even a few millimeters in size. If you're looking at microscopic disease, again, there are studies that are starting to look at whether we can identify the presence of cancer through circulating tumor DNA or some sort of marker of residual cancer in the body as opposed to a scan. Those are still in clinical trials and aren't yet available. I'm not sure that there are anywhere, certainly in New Zealand, that's proven that that's a way of measuring microscopic disease. But that, again, I think is going to be something we see more of as time goes on. There is going to be greater developments of these sort of tumor markers, and circulating tumor DNA is probably going to start being more common as a tool for measuring cancer activity in the future, but it's certainly not in the clinic yet. It's still experimental.
Right. And I mentioned the word tattoo before. We've got a question there about tattoos. Can I get a new tattoo while going through treatment? Now, I'm assuming meaning radiation tattoos rather than tattoos
No, I
on the
think they might
arms
mean a
and the
different type
skeleton.
of tattoo. So
Yeah,
our
okay.
tattoos,
I wasn't quite sure.
our tattoos are tiny dots, and so they'll be just in
Yeah,
the area of the body that we're trying to line up to. And when those are put on during planning, they'll be there definitely for the duration of treatment because they are permanent marks. The tattoos, normal tattoos of skin. So if maybe you've got a tattoo on your chest area or on your arm or wherever, they don't affect the radiation. They're very superficial in the skin layers. They don't affect the radiation treatment at all. In relation to getting a tattoo while going through treatment, the problem is more that if it's in the area that you're having radiation to, that skin's going to be very sensitive and you risk developing an infection in that area. So I really wouldn't recommend it during treatment. If you're having it to a different part of the body, it wouldn't necessarily affect the radiation itself. But again, it might be best just to wait, just because if you have any complications from a tattoo, and I know most tattoos probably wouldn't have complications, but if you get any infection or anything like that, that could impact your ability to attend for radiation treatment. So it might be best to wait until afterwards.
thank you. Look, we've pretty much used up our hour. I'm just very conscious that I just want to check that we've answered everyone's questions. If we haven't, and you do have a thought, after the class, please send an email back to Look Good Feel Better, and I'm sure they'll pass it through to Dr Hardie to answer. Is there anyone that's got anything else? One last question, maybe? Okay. Right, we'll draw it to a close now. I really hope that this has been valuable for everybody that's come online, and we thank you so much for choosing to join in with us. Thank you so much too to Dr Hardie for your time. It's very valuable, and everybody that comes online really appreciates the opportunity to hear things in a nice, relaxed, casual environment as well. So thank you so much. And so thank you for joining us, and please recommend Look Good Feel Better, these kind of classes, to your friends and anyone else that you think that will be of value for you or for them. So thank you very much, everybody, and farewell for the evening.